Buenos días y gracias por la oportunidad de estar con todos ustedes hoy en el día. Don't worry, that'll be the last of the Spanish for this presentation, but no, it's a sincere pleasure and honor to be with you all, our neighbors in Region 2 for Puerto Rico. As Commissioner Bennett elucidated, having these populations that reside in New Jersey but have familial roots in the Caribbean and other countries that are impacted by Zika allows this epidemiologic link that we have to be attuned to in order to mitigate any complications thereafter and also avoid local transmission. So for today's lecture, I would like to provide a general overview of Zika that can help in getting us started in today's discussions and the more in-depth conversations that we'll be having in the breakout rotations. And in particular, I would like to share some of the lessons learned from our experience with emergency public health response in Puerto Rico, particularly focused on neurologic complications following Zika virus infection, such as Guillain-Barré syndrome. So let's see. So just to make sure that we're all on the same page, to begin, Zika virus is a flavivirus transmitted primarily by Aedes species mosquitoes, especially Aedes aegypti, but Aedes albopictus also has the potential to spread disease. We've been surprised that in addition to transmission by an arthropod, that this is the first arthropod-borne virus that can also be transmitted sexually. Moreover, we assume that this virus can also be spread by blood. Although most infected persons have no symptoms, symptoms can include fever, rash, headache, joint pain, conjunctivitis, that is red eyes, and or muscle pains. Infection during pregnancy is a cause of microcephaly and other mental effects that can't be measured immediately after birth. A bit of history. So Zika was first identified in 1947 by the Rockefeller Foundation that was doing studies on yellow fever among mosquitoes in the Zika forest of Uganda when they happened upon this novel virus. And the first human case wasn't identified until 5 years later in 1952. Now, during the next 54 years or so, there was only 13 laboratory-confirmed cases of Zika anywhere in the world. Most of these cases were in African countries, but there was a couple cases identified in Pakistan, in Malaysia, and Indonesia. So starting in 2007, the first large Zika outbreak was identified in the island of Yap in the South Pacific. And here these initial outbreaks are denoted in the light orange color. So in the following years, we saw additional outbreaks identified in other islands in the South Pacific, as well as in Southeast Asia. Sometime in early 2015, we assumed that Zika was introduced into the Americas. In March 2015, it began circulating in northeastern Brazil, and thereafter it started moving northward throughout the rest of South America, as well as into Central America and into the Caribbean, and even reaching the continental United States, with local transmission identified in Miami-Dade County in Florida, as well as in Texas in the latter half of 2016. This is a world map generated by CDC, available on the web, of the areas with risk of Zika as of the 19th of April 2017. And I encourage everybody to be familiar with the resources that are available online via the CDC travel website, especially those for Zika. This map is interactive, so you can zoom in on particular regions, and as we have more areas identified with local transmission, you can actually zoom into the exact counties if we have that data available to make sure that you know where we are identifying Zika, active Zika virus transmission. These maps are a little bit updated from what we were using before, especially to be in line with new WHO recommendations that came out in early March 2017. So in addition to the travel notices for Zika, there are the countries that have reported recent or ongoing Zika virus transmission, and there's a whole list of those countries. we now also include other countries that have been impacted by Zika, that might have a risk of Zika. And these are countries that perhaps don't have locally identified Zika transmission right now, but because we know that they have perhaps the local vectors for Zika, maybe they have reported Zika virus cases in the past, whether it be among humans or through research on mosquitoes, we are also identifying those as other places of risk of Zika. So for example, in Burkina Faso, a country in Western Africa right here, it's a landlocked country. In the early 1980s, they discovered Zika among mosquitoes that they were studying for dengue virus. So now Burkina Faso, which has a relatively poor infrastructure for detecting by laboratory Zika virus infection, we count it among the other places that might have risk of Zika virus infection, just so people can have a better awareness of their potential risk and exposures while traveling around the world and taking the necessary precautions to prevent disease. Further, you'll notice that in this map, we have an updated light purple region, such as the mountains of the Andes and in central Mexico, these areas of high elevation. So we know that Aedes species mosquitoes can't really survive at 2,000 meters, 2 kilometers above sea level, a little bit over a mile. So we anticipate that these areas are a little bit less risk of transmission by mosquitoes, but that doesn't mean that we don't have risk for sexual transmission in those areas as well. So please be sure to check the CDC website regularly so we can stay informed about the areas that have active transmission of Zika, and encourage patients people who might be traveling to also become informed and to take the necessary precautions before they travel and after they return. I'd like to spend some time going over the specific travel guidance that CDC has put forth, and particularly starting with pregnant women. So first and foremost, the CDC recommends that if you are pregnant or are planning on becoming pregnant, to avoid any travel to areas that have ongoing Zika virus transmission. So really, to mitigate this risk of having any exposures, we really are encouraging women to not travel to these regions if at all possible. If, however, a person must travel to a region impacted by Zika, we recommend that these women and their partners first go and talk to their doctors or their healthcare providers about any plans that they might have to become pregnant, and of the risk of contracting Zika and what that might mean for their plans of getting pregnant. And then moreover, once they're in country, to strictly follow recommendations to avoid mosquito bites, and moreover, to avoid any potential for sexual transmission. Right. So in order to protect ourselves while we're traveling, people with a partner who has traveled to an area with the risk of Zika should use condoms or should abstain from sexual contact. And the period of time to do so that the CDC is recommending really differs by females and males. So if the traveler is a female, they should use condoms or not have sex for at least 8 weeks after travel to an area at risk of Zika, or if they do not have symptoms, or for at least 8 weeks from the start of their symptoms or from that diagnosis of Zika virus. If the traveler is male, they should use condoms or not have sex for a period of 6 months after visiting an area at risk for Zika if they do not have symptoms, or at least 6 months after the start of their symptoms or their Zika diagnosis. This extended period of time is because Zika, we've found, has been able to stay longer periods of time in the semen, so there is that prolonged possibility of transmission via sexual contact. For some travelers that become infected while they're traveling, they might not get sick, as we know that the majority of infections are asymptomatic. They have no symptoms. So they should be aware of this possibility for any illnesses that happens not only in country, but also when they return home. So when they speak to their doctors, they should be assured to let their doctors know where they went and during what period, so we can find epidemiologic linkages to determine any risk and maybe then forward patients' specimens for Zika virus testing. There's a couple of things that people can also do while they're traveling in order to mitigate that risk of infection. Number one on that list is to use mosquito repellents, and please visit the CDC website for the list of recommendations on which mosquito repellents should be used. There's a variety on the market there, and we recommend mostly using mosquito, in Puerto Rico at least, using mosquito repellents that have at least 20% DEET. People can also stay protected by staying in places with air conditioning and or that have window and door screens. So ensuring that those mosquitoes that love to stay in these urban areas, that love to be inside to bite and find blood meals, are really staying outside of the places where we're spending large amounts of time sleeping and enjoying our vacations. Further, for those places that don't have air conditioning or screened rooms, CDC recommends the use of bed nets, or when people are doing camping trips outside in places that might have local transmission of Zika. It's important to recognize that even if a person does not feel sick, travelers returning from areas of Zika are at risk of infecting local populations of mosquitoes. So it's important to take the necessary precautions in order to avoid mosquito bites for at least 3 weeks after returning from a Zika endemic area, so that local mosquito populations remain uninfected by Zika. So this is something that we talk about all the time in Puerto Rico. Even after having symptoms, that doesn't mean that this is the time to not take those precautions against mosquito bites. Just because you have disease, that's exactly when you want to have more precautions, so you break those chains of transmissions. You make sure that your local mosquito doesn't get infected, and then that mosquito doesn't go on to bite your neighbor, your family member, or your loved one. And of course, we've learned a lot from our experience with Zika virus over the last year. We've had a lot more answers to the questions that we did a year ago. But we're still learning more, and the questions are still out there. So we encourage everybody to stay up to date, to do their homework, and visit the CDC website for any latest information on recommendations, and especially for travel notices related to Zika. Testing for Zika can be a little bit complicated. So I've developed this timeline to kind of show what we might be expecting. So using the laboratory test to detect Zika virus infection is done according to the body's response to infection. So usually for Zika virus, we start with the bite of an infected mosquito. So I'm not going to have a gif of sexual transmission, but I think that you can all imagine what that might be. So and symptoms will start about 5 to 7 days later, and they'll self-resolve within about a week if the patient has symptoms. In serum samples, we see that viral RNA can be detected by reverse transcriptase polymerase chain reaction, or RT-PCR, for a median of 14 days post-symptom onset. So really here what we're saying is we're detecting the nucleic acids that are specific to the Zika virus so that we can confirm Zika virus infection among those patients. So an RT-PCR positive result means that that specimen, at that time that the specimen was collected, that patient was indeed infected with Zika virus. Next, we can also test for immunoglobulin M, or IgM, antibodies in order to detect, which can be detected in serum by enzyme-linked immunoabsorbent assay, or ELISA, beginning roughly 4 days post-symptom onset and persisting for several months. So here we're detecting the body's immunitary response to an infection of Zika, those antibodies that might be specific to Zika that happen after an infection. So as compared to RT-PCR, which confirms by detection of nucleic acids, IgM is detecting the response to the body. So it's a little bit one step removed from confirming an infection. Moreover, when we get those IgM positive results, we cannot be completely sure of exactly when the infection happened, right? So especially for our pregnant women, in order to assess the risk of having an infant with congenital birth defects, we see that that risk is highest if infection occurs within the first trimester. So we can't precisely say when that infection happened if we only have IgM positive results by ELISA. Moreover, in a lot of these countries, we see endemicity for other flaviviruses, such as dengue virus. So for people that have traveled often or maybe grew up in these places and might have had a previous dengue exposure, there is the possibility for cross-reactivity upon the test for IgM ELISA. So sometimes we cannot fully differentiate just on an IgM ELISA test between a dengue infection and a Zika infection. Investigations of the persistence of Zika and anti-Zika antibodies in different bodily fluids are still ongoing, but we're starting to get some results. And here are the results from a preliminary report published in the New England Journal of Medicine from a collaboration that CDC has in Puerto Rico to follow people that had confirmed Zika virus infection for several months until we have at least 2 samples that are detected negative for Zika virus infection. So we see that in serum, we can detect it by RT-PCR for a median of 14 days. Yet for some people, we see that they have viral persistence in serum up to 54 days later, so about 2 months after their initial onset of symptoms. In urine, it's a little bit less at 8 days, but we still have some people that are positive in urine up to almost 40 days. And finally, in serum, and here's why we have this precaution to not have sex or to use condoms for those 6 months, we see that in semen, there's viral persistence for a median of 34 days, but certain people have this persistence for much longer. So out of just an utmost abundance of caution, we recommend that people follow those precautions against sexual transmission of Zika for 6 months. Recent Zika outbreaks have surprised public health authorities around the world on a number of levels, including the potential association with Guillain-Barré syndrome. So for the rest of the talk, I'll be focusing on GBS, but I think that a lot of the issues that we found with Guillain-Barré are cross-cutting and can serve to enlighten some of the discussions we'll be having throughout the day. So Guillain-Barré syndrome, or GBS, is an uncommon autoimmune disorder characterized by damage to the peripheral nervous system. GBS usually follows an acute infection and less frequently vaccination, and these infections can be bacterial or viral, such as bacteria such as Campylobacter jejuni, viruses such as arthropod-borne viruses or arboviruses, including chikungunya, dengue, and now Zika. Clinically, GBS presents as progressive, relatively symmetric weakness with diminished deep tendon reflexes. So in interviewing a lot of these Guillain-Barré syndrome patients, they told me that the first indication that something was wrong was that they couldn't press down on the gas pedal. They noticed that something was happening in their extremities, that they lost some sort of strength there. The next day, they might wake up and have a little bit of difficulty getting out of bed, of supporting their weight when they get out of a chair. And then on the third day, they had difficulty walking as that weakness progresses on both sides of the body. And what we try to do is really get to those patients in a timely manner so they can get a diagnosis and initiate treatment as soon as possible to stop that progression. Because when the progression moves up the body and reaches those muscles that control respiration, that's where we see the severe cases. So we really want to mitigate patients to getting to those severe conditions. Guillain-Barré is a relatively uncommon disease with an annual incidence of 1.1 to 1.8 cases per 100,000 population. And this incidence rate it varies by geographic location. We see in northern climates where there's less infectious diseases, we have a lower incidence rate of Guillain-Barré syndrome. And in our tropics, unfortunately, we have not only great sun and beaches, but we also have our higher rates of infectious diseases. So following from that, we have higher rates of Guillain-Barré syndrome as well. The only demographic variable that we see is associated with increased risk of Guillain-Barré syndrome is age, particularly post 50 years of age. So, and this increases after that as well. Our first indication of a possible association between Zika and Guillain-Barré syndrome was from French Polynesia, which is located in the South Pacific. prior to the introduction of Zika virus to the island identified between 3 to 10 cases per year from the years 2000 to 2012. And we can be pretty sure that we're getting all the cases because it's a relatively small population, approximately 275,000 people on the island, and there's only one hospital. So all these severe cases of temporary paralysis will probably be presenting there. So during their Zika virus outbreak in 2013 into 2014, they identified 42 cases of Guillain-Barré with serologic evidence of Zika virus infection. That is, they detected IgM positive results in serum for all 42 cases. So this is a spectacular increase from 3 to 10 all the way to 42 patients. Now, this is still not maybe a large number, but we have to keep in mind that these are very severe cases. A round of intravenous immunoglobulin therapy for each patient costs about $10,000, and auxiliary medical services, including stays in the ICU, brings the price tag up a lot. So preventing infections, preventing Guillain-Barré is very important. The pattern that we saw in French Polynesia seems to have repeated itself in various countries affected by Zika. For example, in northeastern Brazil, in the state of Salvador, they started reporting Zika virus in 2015 with a peak around week 19, which is in May. So with an increase of Zika virus, here denoted by the red line, and low levels of dengue and chikungunya viruses, the maroon and yellow dotted lines respectively, there was an increase in GBS patients, here denoted by the blue boxes. Next, we saw this pattern repeat itself in Colombia. Here is the data from Barranquilla State in northern Colombia. And again, we see that during an outbreak of Zika, which they had at the end of 2015 and into 2016, and with low levels of dengue and chikungunya viruses, we have an increased number of Guillain-Barré syndrome patients. And indeed, this pattern seems to have repeated itself in a number of countries affected by Zika. Here, data from the Dominican Republic as reported by the Pan American Health Organization in the New England Journal last September. So cases of Zika here are denoted by the green boxes on top and GBS by the yellow boxes on the bottom. And we didn't just see that in Dominican Republic. We saw it also in El Salvador, in Honduras, in Suriname, and Venezuela, among other countries. Yet the association between Zika and GBS is difficult to confirm for a variety of reasons, and let me walk you through some of the evidence that we've been collecting. So we have case reports and case series which provide clinical details, yet because this is a rare condition, a little bit less rare with Zika we're finding, the data are limited in scope by the small number of patients described in these case reports and case series. Surveillance data, including those that we've just reviewed, show increased GBS incidence in countries affected by Zika, yet in many settings we see challenges with case definitions for both GBS and Zika virus. So in some places they're not using standardized definitions for GBS. In some places there's difficulty in providing laboratory-based case definitions for Zika. And finally, case control investigations that were conducted in French Polynesia as well as elsewhere have found serologic evidence of infection as a risk factor for GBS. And however, interpreting these serologic results is difficult given that there is dengue endemic in these areas, so there's potential cross-reactivity on IgM results with other flaviviruses. And as we mentioned before, further, there is difficulty in interpreting the timing of infection by these serologic results. So we might have GBS patients that had been infected by Zika, at some point in time have some other trigger for GBS, and that's actually the confounder for what is causing the GBS in those patients. Co-infections is a difficulty to discern for GBS. So going back to our timeline, Given that the median time from antecedent illness or Zika to onset of neurologic signs for GBS is 7 days, there's a very small window of opportunity to confirm a Zika virus infection by RT-PCR among our GBS patients. So let's move on now to Puerto Rico and what happened there. In December 2015, the Puerto Rico Department of Health reported the first locally acquired Zika virus infection. This patient had symptom onset on November 23rd, 2015, and it took a while to confirm this case via a variety of different analyses. The following month, in January 2016, a patient presented to a San Juan area hospital with numbness and progressive weakness, which had been immediately preceded by 2 days of rash. So we were already getting these informations and reports from other countries, and we were starting to think about Zika. This patient went on to be diagnosed with Guillain-Barré syndrome, and laboratory analysis indicated a recent Zika virus infection by IgM results. Importantly, this was a patient within our first 30 confirmed cases of Zika on the island. So already very early on, we were thinking that a similar pattern might emerge on the island. Fortunately, because our colleagues in Brazil, Colombia, and elsewhere affected by Zika were so quick to get the reports out, we were able to work with the Department of Health and CDC in collaboration with other organizations on the island to develop a more robust surveillance for Zika and for its complications. So surveillance in Puerto Rico for arboviruses starts at the Puerto Rico Department of Health with the passive arboviral disease surveillance system, which is run by the Puerto Rico Department of Health. So through this surveillance system, providers across the island can submit with a case report form and patient specimens, mostly serum specimens, for arboviral testing, that is Zika, chikungunya, and dengue. And using the CDC-developed trioplex model, we test concurrently for these 3 arboviruses by RT-PCR. CDC Dengue branch, which is also located in San Juan, Puerto Rico, can detect cases of Zika via 2 different surveillance systems. One is a Sentinel-enhanced dengue surveillance system, which is run out of a hospital in southern part of the island. So all acute febrile illness patients that go into the hospital will be tested for the 3 arboviruses as well as other infectious diseases. And also we have an enhanced fatal surveillance system so that people that die with, following an acute febrile illness are tested for a variety of diseases, including Zika, but also leptospirosis, melioidosis, dengue, and chikungunya. Priority testing for samples from the Puerto Rico Department of Health are forwarded to CDC Dengue branch over the last year in order to get those testing results out quicker. These are particularly for pregnant women so that they can have those results in a timely manner and work with their providers to understand their risks and complications that might ensue, as well as for patients with neurologic complications. Now, in addition to these already established surveillance systems under the emergency response for Zika, the Puerto Rico Department of Health, with support from CDC, established 3 additional surveillance systems. The first was a birth defect surveillance system to test any infant born with a birth defect for Zika virus infection. The next was a screening of all blood donations on the island. And actually, at the end of February, when we, right after these initial cases, we stopped all local donation of blood to establish this screening method, which didn't come back online until April. So all locally donated blood donation units are screened for Zika virus to prevent any circulation of the virus within our stocks, our blood supply. And this is particularly important because of the high rates of asymptomatic infections for Zika. And then also we set up a surveillance system for patients with neurologic complications, which I'll be focusing on in just a bit. Additionally, we have implemented the Zika active pregnancy surveillance system, which is a follow-up and monitoring surveillance system So women who are detected to have been infected with Zika through the passive arboviral disease surveillance system are then monitored. And we go through and do chart review to both monitor for the women and their fetuses and newborn for any adverse medical event. And we plan to follow these infants born to women who had an exposure for Zika for 3 years currently. And hopefully this will help us then tie those families and infants to the necessary services as they develop. So all the data that we collect through these surveillance systems is managed through an integrated data management system, which is shared between the CDC and the Department of Health. And from there, results are reported to health providers. They're reported to the federal level at ArboNet, and they're used for investigations to better understand this emerging threat. So in terms of Guillain-Barré syndrome, one of the first activities that we did was to estimate our baseline incidence. How do we know if we have an increase of GBS if we don't know what we normally will expect for Guillain-Barré? And we did this through a review of medical records of GBS patients who had presented in 9 hospitals across the island from 2012 to 2015. And using insurance data for 2013, which was a year after a dengue epidemic and before the introduction of chikungunya in our epidemic in 2014. So using these data, we estimate that Puerto Rico GBS baseline incidence in 2013 is 1.7 cases per 100,000 population. So this is right in between the expected range of 1.1 to 1.8 cases per 100,000 population. Now, given the population on the island is 3.5 million, this translates to approximately 60 cases of GBS per year, or roughly 5 cases of GBS per month in years without Zika. At the same time, we implemented a surveillance system to identify cases of suspected Guillain-Barré syndrome, as well as other neurologic conditions, as we certainly did not know the full range of neurologic conditions in adults that might be due to an antecedent infection with Zika. And why suspected? Well, we wanted to prioritize getting those samples as early as possible, so we didn't want to wait until confirmed diagnosis of GBS before receiving those specimens. So the earlier we get the specimens, the closer we are to that window of opportunity to confirm Zika virus infection by RT-PCR. Our objectives for the surveillances were threefold. First, to elevate the clinical suspicion across the island for GBS during our Zika virus epidemic. So to make sure that people were thinking about GBS as a possibility beyond other conditions that might be presenting similarly, so that patients, especially presenting at those smaller health clinics, could be referred to places that they had a dedicated neurologic department where they could get a diagnosis and initiate treatment as soon as possible. And personally, I think last year I gave over 90 presentations across the island. So at this point, I know the hospitals much better than I know the beaches. But please come visit. Next, we really, as an epidemiologic department, we wanted to monitor these trends in GBS in order to better prepare to guide planning of resources, including medications and hospital beds. We wanted to be certainly critical that perhaps the trends that we were seeing in other countries were not going to happen in Puerto Rico, but we wanted to stay open to the fact that it might happen. And finally, we wanted to provide these arboviral testing, especially for recent Zika infection among our identified GBS cases. So working on that challenge of the Zika virus case definition among our GBS patients. So in order to report a case, health providers across the island at whatever center that a patient was presenting could report a case of neurologic complication potentially due to Zika using a case report form. These case report forms are available online in both Spanish and English, and I'm happy to forward them to anybody who might be interested. And so any specimens that we would receive, we would test for arbovirus testing for the 3 arboviruses. And we predominantly got serum samples, but we also were testing urine, cerebrospinal fluid if it was available, and or saliva, just to see how the virus was comporting itself in different bodily fluids. A little bit different from the testing algorithm for just Zika cases. For our GBS patients, we tested all samples by RT-PCR and serum and CSF samples by IgM ELISA, just to see if there was something different between these unique populations that went on to develop neurologic symptoms. So following from that, we have 3 case definitions. We have confirmed Zika virus infections. Those were positive for Zika by RT-PCR. We have presumptive Zika infections. Those were negative by RT-PCR, but positive for Zika by IgM ELISA and negative for dengue by IgM ELISA. And finally, we have presumptive flavivirus infections, which were RT-PCR negative, but positive for both dengue and Zika by IgM ELISA. So we wanted to make sure that we're still counting people as, in fact, as GBS, especially since we're asking providers to report suspected cases. So this required us to go back in to do a chart review in order to confirm this diagnosis and to collect more clinical data so that we could do some analyses to better characterize what is a GBS patient with evidence of Zika virus infection. And we did so using the Brighton collaboration criteria to confirm final neurologic diagnosis. And this is an established, standardized set of criteria for Guillain-Barré syndrome, which use clinical presentation of the patient, as well as CSF laboratory analyses and electrophysiologic findings. And I'm happy to expand on that in the questions and answer period. And all of our patients then met GBS Brighton collaboration criteria level 1 through 3. Finally, we also are collecting disability data through a telephone-based interviews conducted at 6-month intervals post-neurologic symptom onset. And here I'll present data, initial data that we've collected that assesses disability using the modified Rankin score, which is a set of validated questions focused on the patient's ability to ambulate or walk around. So, what happened in Puerto Rico? This is our first kind of indication of what happened across the island. These are the number, we identified 120 confirmed GBS cases, and here they are by month of neurologic symptom onset. So we see that indeed we do have something that looks like an epidemic that happened during May to October of last year. Now, adding in this baseline level of about 5 cases per year, we see that indeed in January and also during the summer months of wet mosquito season in Puerto Rico, we had an increase above baseline levels of Guillain-Barré syndrome. If we disaggregate that now by evidence of Zika virus infection, we see that here highlighted in yellow, we see that a large proportion of our patients had evidence of Zika virus infection, 71 out of 120. That's more than half. Moreover, we have identified cases, 33 of those, that had no evidence of Zika virus infection. So in any given year, we still will expect, even if we have an epidemic, to have GBS patients that are due to infections with other pathogens, such as Campylobacter, leptospirosis, influenza, etc. So adding back in our baseline incidence, we see that these GBS patients without evidence of Zika virus infection approximate our baseline incidence levels. Overlaying it with our Zika virus infections detected across the island here with a different y-axis for our Zika virus infections, we see that there is a temporal association between the appearance of Zika on the island and the increase of our GBS patients across the island. And just to highlight this point a little bit more, in the last year, with the collaboration of CDC, we've tested over 100,000 patient specimens for Zika virus infection. That's 100,000 people that had a clinical suspicion of Zika that met specific case definitions, of which we were able to confirm almost 40,000 patients that year. So this is an incredible amount of work that has gone into this project with a lot of deployers, including, I see Luis Torrens, who was an incredible asset last year from New Jersey Department of Health, who was down back in March and April. So we had a lot of deployers that were on the ground helping with a variety of activities in order to get this number, and particularly in order to get those pregnant women the results in a timely manner. We also identify a number of other neurologic conditions that had evidence of Zika virus infection, the largest proportion being among encephalitis patients, but a couple of cases of acute myelitis, neurologic deficit, uveitis, etc. Looking at where these patients were distributed across the island, we saw the largest number was in the San Juan metropolitan region. And ongoing investigation is looking into why that happened. Now, one of the good things about capturing patients that were both Zika positive and Zika negative is now we have an important group from which we can contrast those patients that had evidence of Zika virus infection to define what is a case of GBS with evidence of Zika virus infection. In terms of demographic variables, we see that our patients with evidence of Zika virus infection were more likely to be female in comparison to those patients without evidence of Zika virus infection. In terms of median age, no surprises here. Both groups were over the age of 50, although we had a rather large range as well. Early on, reports were indicating that perhaps Zika was promoting a more severe form of GBS. And through these results, at least in Puerto Rico, we're seeing that there was not actually a quicker progression from acute antecedent illness to neurologic onset. Both groups had 7 days, a median of 7 days, and these patients did not differ in terms of time spent in hospital. Both groups reported high rates of antecedent illness, about 80% for both groups. And unsurprisingly, those GBS patients that had evidence of Zika virus infection had were more likely to report a rash. In terms of neurologic signs and symptoms, these patients were, again, clinically similar to one another, except for one feature, facial paralysis, weakness, and some paresthesia, the numbing of the face as well. And these analyses are ongoing so that we can better define in the acute phase what is one of these patients affected by Zika. So especially in places that don't have the laboratory capacity for testing for Zika, they might see one of these neurologic cases and think Zika so that they can mount a public health response, especially aimed at protecting pregnant women from infection. Again, these patients seem to be very similar in terms of medical intervention, although GBS patients with evidence of Zika virus infection were more likely to require mechanical ventilation. And finally, in the long term, this is a good silver lining. We are seeing that GBS patients are, with or without evidence of Zika virus infection, are very similar in terms of long-term disability. And in fact, at least preliminarily, we're seeing that for about 40%, a large proportion of our Zika GBS patients in yellow are reporting non-significant disability at 6 months, which seems to be a little bit better than their counterparts that don't have evidence of Zika virus infection. So just to wrap it up briefly with a summary of our findings, in Puerto Rico, we've detected 120 cases of GBS in 2016, which certainly was higher than our expected baseline. It's a doubling of our baseline that we estimated for 2013. And using arboviral laboratory surveillance, we were able to identify that the majority of these patients had evidence of Zika virus infection in any specimen submitted. Compared to GBS patients without evidence of Zika virus infection, cases with evidence of Zika virus infection were more likely to be female, have a facial disability in the acute phase of illness, and require mechanical ventilation. And clinical outcomes and long-term disability for these two patient groups seems to be similar. So although we're seeing an increase of GBS during times of Zika virus outbreaks, we can treat these groups as fairly equivalent, at least from the data that we've gathered in Puerto Rico. So with that, I'll be happy to answer any questions. Thank you so much for having me. Yes, please.
What kind of protection are they giving travelers to when they enter the planes from these countries and they may have a mosquito on them or larvae or whatever? What kind of protection are they doing on the airlines?
Yeah, that's a great question. So we've been working extensively with the CDC Department for Global Migration and Quarantine, which actually has one of its sites in the San Juan International Airport. So working with airlines and working with the companies that operate airports to get the messaging about prevention when passengers get off the plane, but also to reinforce that idea that they might have an infection when they leave. So this message that even if they don't have any signs or symptoms before they leave, to watch out for those signs and symptoms upon their return, and moreover to use these methods to avoid mosquito bites when they get back for a period of 3 weeks so that we can mitigate that risk of transmitting to local mosquito populations. It's a difficult, given the volume of passengers, it's quite difficult, but we've been trying to do our best in order to get that message out there. And I think that that's where we require help from places like New Jersey, where there is large connections of populations traveling back and forth, so that these populations are also informed before and after they go to visit family members or to travel on vacation.
When you're testing people that donate blood, when do you reject the blood? Based on the antibodies or based on the PCR?
Yeah, I haven't been so involved with the blood screening, but they use a nucleic acid amplification testing screening method that was approved by the FDA, I think last March 2016. So after the blood is donated, they screen it before it goes into the blood supply. And we track those numbers to look at the prevalence among blood donors for positivity. Yeah, so it's before it enters the blood supply. Yes, here in the front.
Oh, just to follow up on that question, are you seeing evidence of contamination of the blood supply?
So far not, and I think that it was a big hit for blood donation sites in Puerto Rico, but we had good collaborations with those organizations. We really stopped all blood donations on the island, and we're importing blood for almost 6 weeks, from the end of February to early April 2016. And this was really to make sure that any blood that was going to be used, especially if it was going to be used in some sort of emergency situation for pregnant women, we weren't going to be running the risk of Zika virus infection, given that such a large proportion of patients that are infected with Zika don't have any symptoms. So we have not seen that yet.
Some of the specimens accepted for Zika testing were serum, urine, CSF, and saliva.
Mm-hmm.
Why not semen, considering that there's a huge component of sexual transmission too with Zika, along with mosquito?
For Guillain-Barré syndrome?
Yes.
Yes, that's a great question. So there's a couple of responses. Well, first, many of our GBS patients were female, so that's a little bit difficult to get semen there. But also, this is an acute flaccid paralysis, so many patients it's a little bit difficult to get semen specimens from them. So really, we were only asking for additional specimens of CSF, urine, and saliva if it was available. We would have liked to have gone in for more information from bodily fluids. including semen, but unfortunately, we really were dependent on providers submitting the samples. So I think we have 102 serum specimens, 34 CSF specimens, around 50 urine specimens. So we're able to track the positivity by date post-neurologic onset, and at least a preliminary analysis in this particularly special patient group of GBS patients indicates that there's no additional viral persistence beyond what we would expect for a regular case of Zika in any of those 4 specimens. And with saliva, we actually didn't find any of the submitted specimens either for passive surveillance or for a special investigation that had evidence of Zika virus infection. Yeah, that's a great question. I don't know, but I can certainly follow up on that for you. Thank you. Sure. So the question was about the development of Zika virus vaccine. There's several vaccines that are currently in trials, including several that are spearheaded by the NIH. I know that one that has been piloted in Puerto Rico has now just entered phase 2. So, but we don't expect to have a vaccine at the very earliest for several more years. So vaccines will still not be online for some time to come, unfortunately. But people are working on it for sure. Please. Yeah, that's a great question. You know, I think it's confounded the CDC at large even, where we're bringing into people that usually don't have to work together for Zika virus. You have not only our vector-borne disease units, you have our pregnancy and birth defects units, you have the neurologists now, you have a lot of people with their work on HIV, AIDS, and other sexually transmitted diseases that are coming in, and we're all finding a lot of lessons that can be learned and applicable here. So what we try to do is make sure that the message doesn't get lost, because it's this dual risk of not only mosquitoes but sexual transmission. In Puerto Rico, it's rather difficult to discern, given the amount of mosquitoes and endemicity of Zika now, whether it was mosquito-borne or sexually transmitted. So really discerning between mosquito bite or mosquito transmission or sexual is something that is a little bit more apparent once travelers return. So really emphasizing that message here in New Jersey and other places in the continental United States to make sure that those travelers are protecting their partners from that possibility of sexual transmission is of the utmost importance. Yes, please. Sure. Yeah, there's several investigations that are ongoing. If I know the article you're talking about, it's based off of an article in Cell magazine that looked at 14 rhesus monkeys and the viral persistence in CSF. So this is our first indication about maybe viral persistence. And one of the reasons why they're thinking that we saw such persistence in CSF is that they found no IgM antibodies to fight off infection within the CSF. So those are in rhesus monkeys. At least the data that we're collecting from these 34 specimens for CSF in our Guillain-Barré syndrome patients is that actually we only found 1 out of those 34 that was positive by RT-PCR for Zika. We had a handful, about 14, a little bit more than a handful, about 14 that had IgM positive results in CSF. So we're certainly, at least from our data in Puerto Rico, not seeing viral persistence in CSF for our human patients that went on to have GBS. But certainly, this is just a small sample size, and working with other partners across the world really to get bigger sample sizes is what's necessary now. Yeah.
So we have time for one more question.
And of course, I'll be walking around if anybody would like to grab me.
Can you just touch on microcephaly and the numbers in Puerto Rico and incident rate to date?
Sure. So as I mentioned, we follow these women who test positive for Zika through the ZAPS, Zika Active Pregnancy Surveillance System. And to date, from 2016 to 2017, as of last Friday, the Puerto Rico Department of Health is reporting 3,531 cases of Zika virus infection among pregnant women. And we have detected 35 cases of congenital birth defects that we can say are associated to Zika. This is ongoing as well. We have a fairly, the Department of Health is reviewing every single case, and as we know, right after birth, certain cases might seem to have microcephaly or other signs of congenital birth defect, but it might take a little bit of time to confirm those cases. So those follow-up surveys are really ongoing. So we anticipate that those numbers will be reported on a weekly basis through the Department of Health. Muchas gracias. Thank you.